So, I told you I was going to skip through the first three pretty quick. Insights into healthcare spending on Medicare, Medicaid in the U.S. Because this is where sort of the meat of the matter is. How do governments go about improving health and healthcare through their healthcare spending? What are their objectives for each of these parts? And again, I said we're going to talk about financing, delivery, and come back to financing, reimbursement, and come back to delivery at the end. But how do governments achieve those objectives? And this is kind of a little bit of things that I've picked up over the years. It's a little different from how the Governors Association looks at it. But if you're a policy advisor, a policymaker, you've got to realize your tools, your levers are limited to kind of these four things. You can give people money, grants, rebates. You can tax them, take money away, or fine them. You can regulate them. You can do this, you can't do that. Of course, if you violate the regulations and you're caught, you get threatened with money or prison. Government has a big role in the bully pulpit or convening or coordinating. It's a lot of what I did in the Governors Association. The president gets up and, the entire State of the Union is one big bully pulpit. Rarely does the president, not in my memory or maybe even the last 100 years, say we are going to do this and these are the specifics of this new agenda, this new initiative, or this new legislation he's going to propose. A lot of big picture things. And then of course, the federal government, you make war, or you can imprison people if you're also the states. So the question is, how do the government use those levers to try and achieve better health, better health care? And again, there are differences between state and federal government, particularly beyond the war issue. And again, different states, very different constitutions, very different capabilities. We'll talk a little about that. In terms of the government health programs, we're going to talk mostly about Medicare and Medicaid because that's where most of the financing, the spending is. But there's also government employees. A bunch of you are government employees, right? FEHBP, Federal Employees Health Benefits Plan, right? Familiar with that? There's also the Veterans Administration, big in the news, DOD, 340B, some of these clinics, the Zika, the 1.1 billion for Zika money, that's kind of going for healthcare stuff. Tax deductibility of health benefits. Some people get into tax policy, and this is a big issue. A lot of money, if you count that as spending on healthcare, because employers don't pay taxes on their health benefits. And then delivery, there's different federal organizations. I had to throw Hansen's disease in here because that was one of the first things I worked on when I was working for Barry. Hansen's disease is leprosy. Then the states have public hospitals, research the variety of different federal agencies, public health, a few federal agencies, and a lot of state and local health departments where public health really happens on the ground. And there's other things I left out. There's just a whole long slew of them. So what is Medicare? Right? I'm going to try to make this really simple so you can carry with you for the next 30 years when you're doing policy. Medicare is a federal program for the elderly and disabled. You care for the elderly. That's the way to remember it, right? It has four parts. Part A is hospital care. Part B is outpatient care. Part C is basically like managed care HMO. And it combines A and B. It's now called Medicare Advantage. It's had at least 3 different names over the years. Part D started in 2006, and it's a prescription drug plan. And it wasn't named D for drugs. It was just after C in the statute. It just happened to work out that way. And then if you have a Part C plan, a Medicare Advantage plan that also has a prescription drug, there we go. Also has a prescription drug plan, MAPDP. As I said before, Medicare is 22% of healthcare spending. That was in that pie chart. It's about 60% of federal healthcare spending and about 30% of all federal mandatory spending. So the first chart I showed with the major health programs, most of that is Medicare. This is where the money goes to. Remember, there's a little bit of parallelism here. About 25% in hospital services, that's Part A. About 11% direct physician payments, and then 12% prescription drugs, and then it's about 27%, close to 30% Part C, which is get A plus B, and then a variety of these other things are spread out. It's mostly B, but some Part A. So every service is defined as whether it's going to be covered under Part A, Part B, or Part D. And if you're in Part C, it's a combination of A and B. And that matters if you're a Medicare enrollee because there are different cost-sharing requirements, hospital deductible, co-payment amounts, and there's a variety of different ways that that's put into statute and implemented.
So Part C is a choice that
Medicare
a
enrollees,
person makes a choice
they have to
do
enroll
that.
in it, and they have to stay in it for the entire year unless something dramatic happens. They move or something happens with the plan. So it's like you sign up for a, and it's different because, as we'll talk about, for these parts, the government basically pays the bills. Here, the government's basically buying a plan, paying a monthly premium. Is that clear to everybody? We'll get into a little more detail. So if you go to the hospital, the government pays that for that hospitalization. If you're in Part C, the government's paying a premium for that managed care plan for you for the month. If you're in Medicare. How are each of them financed? This is if you're a policy. Now, this is important to know if you're a policy person or a policy analyst, or you're trying to figure out deficits or debts. Part A, which is the hospital part, is paid for almost exclusively with payroll taxes. So when you get your paycheck, your pay stub, and it's got, it used to be called FICA deduction. I think it's now broken out separately as Medicare. This is the hospital, the Medicare trust fund that everybody's talking about sporadically is running out of money. Almost the entire thing comes from this trust fund. Part B, which is the doctors and outpatient, remember A was the hospitals, there's no trust fund, there's no payroll deduction for that. 3/4 of that comes from general revenues of the federal government, and then roughly 1/4 from premiums from individuals who were enrolled. Part A, when you retire, if you've paid in 40 quarters, you're automatically in Part A. You have to sign up for Part B and pay these premiums. It's such a good deal. Everybody does it unless they forget, and then that's a problem. Part D is very similar to Part B with general revenues and then premiums. Premiums, if you're low income, Medicaid pays your premium. We'll get into that. And Medicaid and Medicare enrolled. And then the rest is regular premiums. Part D, since you brought it up, is like Part C in that the government's not paying for individual drugs. You go to the Medicare enrollee goes to the drugstore, picks up a prescription. The government isn't paying for that individual prescription. The government is actually paying a premium or a portion of the premium for like a health insurance benefit plan to an insurance company just for the drugs, which is one reason there's a lot of the Medicare Part C and Part D combined together, because then one organization provides it all through a combined premium. This is a key point in terms of healthcare, as it's different than other kinds of programs. We'll come back to this. But 10% of Medicare enrollees represent about 60% of all spending. So there's a widespread, and I'll come back and I'll show you some other data about national health spending. And this is true for kind of any population you want to pick, not just Medicare. A big employer, people in a state, this kind of spread happens all the time. Variation in Medicare spending. It's actually pretty interesting. This is old data, but it hasn't changed that much. But spending ranges from this is again from 2005, so it's probably double this by now. But back then it was about $6,000 to $12,000 plus minus, different parts of the country. So if you're a policy analyst trying to figure out where the money is, this is a little bit one indication. You can look at geographic variation, as well as sort of differential populations or subpopulations within the entire Medicare enrollment population. Now, what drives higher spending? I want to put this in here. Medicare is apparently higher utilization. And this was known for a long time because Medicare's got good data. And they went and they looked and said, oh, we're using a lot of services, and the Medicare enrollees are getting lots of different kinds of healthcare, and that's what's driving the growth in spending. And that was taken as, that's what drives the growth in healthcare spending. And somebody finally looked at sort of the private sector, and they found out it's actually prices. Because people went and looked, particularly they went down and looked at this part of Texas, and Atul Gawande wrote an article, and he said, it's utilization is through the roof. Well, the private sector went and looked at McAllen, Texas, and said, our utilization's not through the roof. Our problems are in places where we're paying high prices. Yeah?
Doctor, is that because there's a difference in price paid to Big Pharma?
No. It's, the prices are for a variety of things. A lot of it's hospitals and doctors. Medicare gets generally a better price, and a lot of private insurers pay based upon a Medicare rate plus. or percentage plus in Medicare. And it varies all over the place. The one thing about the U.S. healthcare system is there's almost no such thing as a price for a thing. Even with the Medicare, it varies dramatically across the country, but across payers, it varies even more so. There are list prices, and then for like the VA and Medicaid, Medicaid's, for the VA, there are set prices for certain things they buy, but that's kind of about it because all the Medicaid programs are different too, which we'll get at in a minute. But the lesson here is, as a policy analyst, if you're modeling something, be careful about what you're extrapolating. Yeah?
Quick question. I'm not that familiar with Medicare, but this goes back to big pharma.
Mm-hmm.
When they have a specific list under certain formulary agreements, don't they negotiate those rates down and do a series of like rebates and others to offset that outlay?
Yes.
Okay.
Yeah, I got a slide in a minute that talks about actually pharma complications of pricing.
The supply chain.
And what's your name?
Charlotte.
Charlotte, raise your hand and remind me, and I'll come back and talk to you a little about the complexities and variations of pricing. Okay, so Medicaid. This is I'm oversimplifying a lot of this, but Medicaid is a lot like Medicare. You'll probably never hear any other policy analyst or somebody else refer to it this way. But it's a lot like Medicare. It's a government program, except how it's not. Okay? Remember I said Medicare is for the elderly? Well, Medicaid is for the low incomes. You care for the elderly, you aid the poor. It's a state program, but it's run under federal rules. And Medicare is one program. Medicaid is 51 different programs, plus there's 5 more for the states and territories. Or for not the states, the territories. 51 states, including DC, and then the 5 for the territories. The financing comes as a federal match to the state programs called an FMAP, and that varies by state, varies by type of service. The minimum they get is 50% match. The federal government pays 50%, states pay 50%. But it can go up to, I think, a maximum of about 82?
Over the state ones?
Yeah, state match.
Probably about right. Yeah.
Something around that. It varies based upon income and other things, average income, percentage of poverty for the state, so it varies year to year. And like things like family planning services, the federal government pays 90% to every state. And then there's many waivers. So even though there's 51 programs within each state, even the small states, there can be 3 or 4 different waivers they're running it under for different populations, for different types of services. And also, states, balanced budget requirements. 49 of the 50 states have balanced budget requirements. Is that right? So the federal government, as you know, runs a deficit. The states don't. However, states have a lot of, I'm going to use the word gimmicks, they have a lot of maneuvers to get around sort of the balanced budget requirements, and they also have a lot of ways to sort of enhance how much they get for their FMAP. There's a lot of, Tom Scully, somebody that Barry and I both know, rails on this, the maneuvers the states use to try and get more money by sort of recycling the same dollars again and again and again and getting matching dollars for each time it goes round. It's been a big issue. The states like it, and the members of Congress from those states like that their states get more money, but other people kind of don't like it so much.
If I may just add, if you were a budget analyst, for example, at OEB, you would be intimately involved in these many waivers that.
Oh yeah, it's waiver like a regulation. It's got to be approved by the secretary, and most of them, OMB gets involved. And in fact, the Romney Care waiver, I was living in Massachusetts at the time, that was done under a waiver, and that was a whole big, process. And politicians and Ted Kennedy got involved, and I think the president got involved. And
told the story before. I can still remember being over in the old building and seeing Governor Romney come down the hall with about 4 or 5, 6 foot fellows with him. And I knew it was over. We'd been trying to block it for months, but we knew that the game was over. It was going to be approved. And it was.
And there were budgetary maneuvers done in the modeling to make it all work out so that it could be approved under a sort of a gentleman's agreement, even though people knew that the numbers weren't going to work out exactly the way they had projected. In terms of Medicaid, this is one of the big issues has been expansion from the different states. You probably have heard of the Supreme Court case about this. So 19 states still have not expanded their Medicaid. But this is a very simplistic chart to explain what Medicaid is, who it covers, and what expansion is all about. So traditional Medicaid, I don't know if you guys can read this, but you had to be categorically eligible for original Medicaid. This is kids, parents, which is adults with kids by definition, disabled, and the elderly. And the youngest kids were eligible up to 133, 138% of poverty. This is the poverty level, percent of poverty income. And then from there, every state had different levels that they would cover for different categories. The ACA in the Medicaid expansion for the states that decided to expand basically bumped all that up to 100% and then bumped it up to 133, 138%. And added childless adults who weren't disabled and weren't elderly. So if before the ACA, if you were a childless, able-bodied adult under 65 and you made zero income or $10 for the entire year, you were ineligible for Medicaid in any place in the country. This is the biggest part of the expansion population, as well as bumping up all these people.
This is a great chart.
Thank you, Barry. I think
Presenting
it's
a lot of
incredibly
information
silly, but
in
it
one
gets the
place.
message apart.
I'm sorry, I thought for CHIP, under the CHIP Act.
Uh-oh, somebody who knows a lot. What? Go ahead, John.
I thought that they raised the poverty level to about 300%. So a family that makes $88,000 are technically, their children are technically eligible to.
For S-chip?
I thought that's what.
I don't recall that.
250%?
Maybe. Before the ACA?
No, not before the ACA.
Well, what the ACA did, and I will confess to not knowing everything about most things, but what the ACA did was, this is where it got a little messed up, because the framers of the ACA expected every state to expand Medicaid. From 100% to 400% of poverty, you can get subsidies through the exchange plan. So you buy an exchange plan. If you're right at a little over 100%, then basically most of your premium, almost all of your premium gets paid by the government as a subsidy, so you can get insurance. So I remember hearing something about S-chip expansion, but I thought it was maybe before the ACA. But maybe we can email back and forth because I don't know enough to give you a definitive answer. But that was one of the issues. But so the situation came in. If you're in a state without Medicaid expansion, if you're in this group or up here, if you're an able-bodied adult above 100% of poverty, you can get essentially free insurance or very low-cost insurance through the exchange. But if you're in a non-expansion state and you're down here, you're only making 50% of the poverty level, you have no options. You can buy an exchange plan, but you have to pay 100% of it. It was a loophole or a problem the framers of the ACA didn't foresee, because they didn't think any states were not going to expand.